And I'm just trying to share, just bear with a second. I'm just going to ask for someone to give me a thumbs up when some slides come through onto the screen. Yeah, brilliant. My name's Jane Needham. I'm Director of Strategy, Partnerships and Population Health at Derbyshire Community Health Services, which is the community NHS provider in Derbyshire. Thanks for the thumbs up, everybody. And I'm the Senior Responsible Officer for Population Health Management in the Joined Up Care Derbyshire system. I'm joined by some great colleagues on the call from our two local authorities and from colleagues who work with me on the Stay Well agenda. So I've got Matt, Eves and Rebecca Symes, who are joining me, who work with me on the public health work within Derbyshire Community Health Services. And I've got Tom Dunn, who works in public health in the County Council, and Rob Smithers and Ange O'Dell, who work on in the public health teams in the Derby City Council. So between us, we're hoping to be able to answer any of the questions that you might pop into the chat, or any questions that might generate from the discussion that we're going to be having in a short while once I've just run through the Stay Well agenda. So it's lovely to see so many people on the call. We did a session, I think it was Tuesday evening last week, and there's we had great engagement on that session, but I can see we've got even more people on the call this time. So I've been asked to come and talk around the integrated care strategy, and in particular to look at the key area of focus, which is Stay Well. So the integrated care strategy is just about to be published, and as Beth said, it's got three areas of focus around start well, stay well, and then live, age well, die well. Start well is focusing on school readiness for children. Age well, die well is focusing on community transformation to enable people to stay at home and to either prevent them going into hospital or to ensure that people get out of hospital as quickly as possible. And the area of focus that we're looking at here and now is the stay well area of focus. And in particular, these three key areas of focus, what they're intended to do is to test in Joined Up Care Derbyshire, which is the structural kind of joint organisational form that we've got in Derbyshire, to see how through integrated working of our voluntary sector, working with our communities, working with NHS organisations and working with our local authority partners, how altogether the combined efforts of all of our work will be greater than if we work and act singularly. So that's the purpose of the three key areas of focus. And as we move through the presentation, what I'll be looking to do is to cover certain topics, so that hopefully it's a bit of a story that we begin to tell around why the Stay Well area of focus has been designed in the way it has and why that is important. So what I want to cover initially is a few key definitions, and those definitions are terms that people will use frequently and which we'd really like to make sure from the outset we've got a shared understanding of what they mean. So it's that point Beth was making around, we tend to lapse into using acronyms or using complex words within the organisations that we work. So it's just to try and really pull me up right from the outset to make sure that I'm being really clear with everyone on the call when we use these terms, what it is that we're meaning. To then move on to what the definition of the Stay Well key area of focus is, and then to give a rationale as to why that area of focus has been chosen by Joined Up Care Derbyshire, colleagues, communities, organisations as being really important for us in order to test this integrated way of working. If we get it right, what is it that we hope to achieve? How do we intend to go about it? And then what have we already got in place? Because we know we're not going from a standing start here. We know that there is loads of brilliant work going in, both in terms of what's already going on in our communities, what different organisations are doing and the voluntary and community sector are doing. So to kind of give a bit of a real point of, we're not starting at this from scratch. We know that what we're looking to do is to build on already great services that are in place, but we're not getting it right in all areas, and that's what we really want to come into in that discussion point at the end. So what do some of the words mean that that we'll be using as I move through this presentation? So, and I make no apologies for the simplicity of what I'm just going to say. A lot of people might think, well, I've heard this before, but there will be people on the call, and certainly as this goes out to the public, for which these are terms that they may never have heard of, or that they've heard of but have yet to have kind of like that real understanding and explanation of what they mean. So life expectancy is the average number of years that we can expect people to live for. So the age at which you can expect to die, and it varies by geographical area. So what we know is across the country, not only in Derbyshire, is that depending upon the geographical area that you live in, that is a determining factor for how long you can expect to live for. Healthy life expectancy is a really important term, and that's the term that describes how long you can expect to live in good health for. So you might live a long time, but if you're spending those years in poor health, that's not as rewarding as if you've got a healthy life expectancy. An early death, when we use the term early death, means someone who passes away at an age that is younger than the life expectancy for that area. So if you live in a geographical area where the healthy life expectancy is, for example, 83 if you're female, if you die at 72, then you're considered to have had an early death. And then health inequalities is a term which is used much more frequently now, and particularly post-COVID or during COVID and post-COVID. And health inequalities is a term which is used to describe the unfair and avoidable differences in health between different groups. And the two key words to really remember there is unfair and avoidable. So if we did things differently, if we focused our efforts differently, then these health inequalities differences in life expectancies, in healthy life expectancies, in outcomes and experience for people between different groups within our society, we could address them and reduce that inequity. Risk behaviours, come on to those last two terms that I'm going to be covering here. Risk behaviours are actions, habits or behaviours such as smoking, the amount of physical activity that we take, and the amount of alcohol that we consume, whether our diet is considered healthy or poor. So those risk behaviours are actions that we take ourselves, which have a determining factor on our health and contribute to our risk of illness and of death. And then risk factors is when a risk behaviour causes a condition that increases the likelihood of ill health. So for example, we know that smoking, the evidence, and I won't be telling anyone anything they don't know, we know that smoking contributes towards an increased risk of cancer, an increased risk of heart disease. So therefore that smoking behaviour becomes a risk factor for increasing your chance of illness. So those are really key terms that we use within public health language, and certainly within this stay well area of focus. And so I just wanted to make sure that everyone was on the same page with those before we go on to look in more detail around the terminology that we've come up with for the stay well key area of focus. So it's quite wordy. I'll kind of talk you through the wordiness and then cut to the chase on what does it actually mean. So within the strategy, the stay well area of focus is described as our focus is to improve the prevention and early intervention of the three main clinical causes of ill health and early death in the Derby and Derbyshire population. And we know that those three clinical conditions are circulatory disease, and examples of circulatory disease is high blood pressure, stroke, heart disease. Respiratory disease, that's the second one, and we know examples of that include asthma, COPD, which means chronic obstructive pulmonary disease, and then cancers, and all of the main, we've put up some of the common cancers, but cancer in the round, those are the three clinical conditions that are most likely to make someone die early or to spend a greater proportion of their time in ill health. So what we want to do is to prevent them in the first place, or identify them as soon as possible in order that we can either cure them or ensure that life is extended as long as possible and that symptoms are managed as well as possible by identifying the disease early. And the rationale for choosing this as an area of focus and those three clinical conditions is rooted in the data that we have around what is causing people to die early within Derbyshire. And in Derby and Derbyshire, the three main causes of ill health and early death are those three diseases, so cancer, circulatory disease and respiratory disease. And together they cause 2 out of all 3 early deaths in Derby and Derbyshire. So 2/3 of the reason why people die prematurely for the age that they could be expected to die are down to those 3 diseases. And because we know how those diseases occur within populations, we know that many of them are avoidable because of those risk behaviours and risk factors that I talked about when we on that earlier slide. And then when I go on to think about inequalities, so again, a bit more of a rationale as to why focusing on these 3 diseases feels really important. The difference we know from the data in how long someone is expected to live between our poorest areas in the county and the city and our wealthiest areas in the county and city is almost 9 years for men and almost 8 years for women. So put simply, that means that someone in our most affluent area, our richest areas, wealthiest areas, can expect to live 9 years longer than someone who lives in our most deprived areas if they're a man, and 8 years longer if they're a woman. So again, make no excuses. People who know me will have heard me say this before. That means that if you live in a wealthy area, you will be able to see your grandchild grow up, and if you live in a poorer area, then you probably, then the statistics indicate that that is less likely. And what we also know is that those three diseases, cancer, respiratory and circulatory conditions, account for more than half of that difference in health inequalities in life expectancies between our wealthiest and our poorest areas. So that really kind of consolidated our rationale at a system level. So the decision made by people in a number of different organisations and then taking it into the Joined Up Care Derbyshire organisational system to say, what should we focus on for Stay Well? This kind of the contribution that cancer, respiratory and circulatory disease make towards early death and towards health inequalities provided us with that evidence as to why we need to focus on preventing these diseases in the first place or identifying them as early as possible. So then what I wanted to do, what we wanted to make sure people kind of really, we were explaining fully to you is what we mean by prevention. So again, a word that's used really commonly, and sometimes people are not really clear on exactly what it means. And prevention means stop it. Primary prevention, which is what we are particularly interested in, means stopping people getting the disease in the first place. And we talk about it in terms of upstream interventions. And this image here is something that really helps to visualise what do we mean by upstream. And upstream means we put into place actions or interventions that stop people falling in the river in the first place. It is far better to stop someone falling in the river than to allow them to fall in, i.e. get the disease, become unwell, and then fish them out at some point further downstream, and the further downstream the worse, in order to, which is where the analogy of that's where we start to treat them. So we want to make sure someone doesn't get the disease in the first place, doesn't fall in the river, rather than allow them to fall in, get the disease, and then we have to hoik them out, which is the treatment. So that is what we're looking to try and do with this Stay Well area of focus. So if it all goes well and we're looking back on this in 3, 4, 5, 10 years time, how will we know if we've made progress? So what we have is a lot of data which indicates what ages people are becoming unwell at, and what from these diseases now, and how long people spend in ill health, and at what age they die across the geographical area of Derby and Derbyshire. So if we really get this right, what we are hoping to achieve is that we will enable people to live longer, fulfilled and healthier lives. And my perception of what that means is very personal to me and will be very different to everyone on the call. So it's not just about living as long as possible for everybody. It is around ensuring that the life that you live is as healthy and as fulfilled as it possibly can be for what is your own vision for your own life and for that of your family and your friends. So how will we know if we've made progress? Well, we'll be able to look at the data and show that we have begun to extend healthy life expectancy. And in the first instance, that will be by months, and then hopefully it will start to be by years, and that healthy life expectancy for all. And what we want to make sure that we also really focus on is reducing that gap in health inequalities between our poorest and our most wealthy areas. So we really want to make sure that we enable and focus our efforts on allowing those more deprived areas to catch up with our more affluent areas. So it's not about slowing down healthy life expectancy or life expectancy in our wealthiest areas. It's around allowing those poorest areas to catch up. And what does that mean that we need to do? And when I say we, I'm not just talking about those sort of 5 or 6 people that I mentioned at the start. This is the collective efforts of us as residents of Derbyshire, as people working in Derbyshire, and as organisations and communities who contribute towards health and wellbeing within the Derbyshire population. So we want to make sure that we identify what makes it more likely that people will develop these 3 diseases. identify the actions that are going to be most effective to reduce that likelihood of people getting those diseases in the first place. And the most important point that we absolutely know we are not getting right at the moment, and that we can really build on, is that we know that if we speak to communities, we need to really listen to what they're telling us in terms of how those interventions need to be tailored in order to respond to those needs, and how local populations across Derby and Derbyshire will engage with the interventions that are put into place. So put simply, we know from the evidence and from the intelligence that we have what makes people in the first place. We know which interventions are more likely to help people to stay well or to recover quickly. What we need to really specialise in is to listen to our communities to say, taking that information about what makes people ill and what will prevent them from becoming ill, how can we tailor it and engage with local communities to make sure we are delivering those interventions and engaging with our communities in the best ways possible, to make sure that those actions and interventions are easy for those populations to access and to benefit from. And then we want to look to work together with communities to deliver these actions. So that's what we're looking to hope to achieve. And just as I move through into these last few slides, so let's think about a particular example of prevention and early intervention. And if we think about it in terms of a risk behaviour for smoking, what we know is that if you smoke, that gives you an increased risk factor of getting high blood pressure. And it also exposes you to carcinogens. So those are, by carcinogens, we mean substances that are likely to increase your risk of getting cancer. And then what we know is that those risk factors of high blood pressure and exposure to cancer-causing compounds are more likely to then lead for you to have circulatory disease. So those kind of diseases that I talked about at the start, so elevated blood pressure, heart failure, etc., or cancers. So by doing this tracking of smoking causes high blood pressure and exposure to carcinogens, which then cause you to go on to have an illness, that is the kind of tracking that we want to do. But fundamentally, most important is to really get behind what causes people to have these risk behaviours in the first place. And what we know is that those risk behaviours are more likely to be more prevalent in or exist more in certain population groups, and they are more likely to be more concentrated in those areas of Derby and Derbyshire which are more deprived, so are poorer. If we look at it again, another example here is around poor diet. So risk behaviour is poor diet, so not eating as healthily as is possible. And there are loads of factors behind that, not least the cost of living crisis or the period of austerity that we experienced sort of post 2009 onwards. So we know that poor diet is a risk factor for high fasting blood sugar. So when you've got elevated levels of sugar in your blood, which is then a risk factor for circulatory disease or cancer. So if we can get behind what are the reasons why people have a poor diet, what is it that we can do to make sure within those communities that we are helping those communities to be able to access healthier food and to understand how to cook and provide healthier food for themselves, for their families, and for their kind of communities. So, as I said earlier, we're not starting from scratch here. This is not like we haven't got anything in place. We've got great things in place already. It's just that we're really aware that that they may not be being accessed by those people who most need our help, and we are not engaging with those communities or we're not listening to those communities who most need our help. So that kind of insight from local communities is really, really important. So examples of things that we've got in place already is that across Derby and Derbyshire, we've already got the NHS Health Checks programme in place. And that is basically where if you have not already engaged or with your local GP and you're between the age of 40 and 74, then you'll be invited to attend for a free checkup of overall health. And it identifies very early those risk factors or those risk behaviours and therefore risk factors of going on to get disease. And those common diseases are, the cancer, circulatory, respiratory. The health checks are really, really tailored to try and pick up those risk behaviours and risk factors. So we've already got that in our GP and communities across Derby and Derbyshire. So there's lots of interventions already happening around that. And there's also routine blood pressure checks, which to identify high blood pressure, which is a risk factor for circulatory disease. And they're carried out in workplaces, at various events across Derbyshire as one-offs, and also in our local pharmacies. So we've got this kind of work already going on in and around Derbyshire. What we've also got in Derby and Derbyshire, and Rob, Ange and Tom, who are on the call, will be able to talk in much more detail about this, are our wellbeing services, which sit into the 2 local authorities. So within Derby City, we've got Live Well, which does smoking cessation services, does lifestyle services around weight management, healthy diet, physical activity advice, and exactly the same in Derbyshire for residents of Derbyshire in Live Life Better Derbyshire. So they're called slightly different things: Live Well in Derby City, Live Life Better in Derbyshire, but they are our 2 local authority run lifestyle and wellbeing services. And really importantly, because these services recognise that what causes someone to have those behaviours that are more likely to lead to disease is rooted in things like income, employment, your housing conditions, the areas that you live in, whether they're more deprived or not, then those services also start to give, or also are able to provide access to housing and benefit advice, access to alcohol misuse advice, mental wellbeing advice, because all of those factors really play into risk-taking and risk-causing behaviours. So moving on to what we really wanted to talk about here is why your views matter, and why it's brilliant that there's a number of people on the call here who we know will have fantastic insight to help us shape this next stage of what we want to put into place for this Stay Well area of focus. So your views really matter because we know the main causes of ill health and early death. They're really well documented and there's strong evidence around them, and we've got the data locally to know what those are. We absolutely know it's better to prevent an illness before it happens, so to stop someone becoming unwell, to catch them upstream. And we know what services are already available in Derby and Derbyshire. But we know that those services, despite all of that in place, there is still an increasing likelihood within Derbyshire, and increasing data in Derbyshire, which is showing us that people are still becoming unwell from those diseases. And as is happening nationally, the increase in life expectancy, which was showing in public health data, is beginning to now level off, and particularly during COVID and after COVID, is beginning to level off, and in some areas is beginning to have a downtick. So that means what was a healthy life expectancy, or life expectancy of 5 or 6 years ago, is now actually earlier. So life expectancy is beginning to shorten in some of our more deprived areas, and that is what we really need to dig into communities and say, how can we help? What is it that we need to do to ensure that this life expectancy, we begin to get an increase again, and we begin to see healthy life expectancy really coming to the fore? So your views matter. Feedbacks from today's session will be used to shape this next step in our key area of focus. So the questions that we really wanted to think about, and I shall cut and paste them up into the chat so that when I take the slide down, you've still got access to them, is thinking about those 3 clinical areas in particular: cancer, circulatory respiratory disease. What matters to you as individuals, people representing communities, or people representing our organisations working the system? What really matters to you in terms of those 3 clinical areas? What's working well? What do you see as the gaps? And what actions would you like to make sure that we absolutely embed into the work that we're going to be taking forward to make sure that we start to have a positive impact on this Stay Well area of focus? So I'm going to take the slide set down now. I should have stopped presenting and bring it up onto the mainstream. So hopefully, Beth, that's given enough as a starting point. I think, are you going to be fielding the questions, which I know Tom, Matt, Rebecca, Ange and Rob and I will all do our best to answer?
Yes, wonderful, Jane. Thank you ever so much. So just a couple of options if you want to ask questions. So you can either pop a question in the chat box, and we'll alternate between chat box and people who've got your hands up, or you can again press on that raise hand, and we'll come to you as well. So to start with, we have one hand up. Aman, sorry, I apologise if I'm pronouncing that wrong. Would you like to ask a question?
Good morning, all. Hi, it's Amran. No worries for getting it wrong. Just to, I know we're talking about certain health conditions, but I do have something that kind of does fit in with the wider ICB, and that's having a severe mental illness. and your life expectancy with regards to having that illness as well. Is that something that is going to be dealt with the mental health service, or is that something that the ICB is going to tackle as well? Thank you.
Thanks, Amran. Nice to hear you on the call. So it's a really interesting point you're making, and a very important one, because through the development of the strategy, there was a lot of feedback to us of why isn't mental health kind of like a key area of focus in its own right, and there was a lot of discussion, debate about how we should do that. So the first thing I really want to assure you about is that there is no physical health without mental health, and I think everyone who's leading on these 3 key areas of focus is very, very clear on that. What we want to do is to ensure, because the inequalities, as I talked about, the inequalities we know exist between geographical areas, we also know there are inequalities between those people who experience mental ill health and the general population in terms of those 3 clinical conditions. So what we have got is colleagues who are specialists within mental health who will be walking this kind of priority with us to make sure, and we really want robust check and challenge from them, just as you're doing now, to say, hang on, you've slipped a bit there with regard to ensuring that you're providing adequate consideration of people with mental ill health problems. And what we want to learn from our communities, Amran, such as you're doing there, is how do we, so if, for example, Rob in the city is delivering a Live Well service around weight management, how do we make sure that not only are we tailoring it into those areas of the city geographically where we know people are most likely to need those services but least likely to come forward, how are we tailoring them to make sure that they are engaging and provide great access for people for whom mental ill health is also a factor in whether they do, or whether they would want to address their weight. So we know we need to embed mental health. And the way in which we want to do it is to make sure we're constantly getting really robust check and challenge from people such as yourself, and really listening to our communities as to how we can make sure that we are providing services to people who are experiencing mental ill health at that particular point in time. So I think it's more a request from me of, please can you help us to make sure and to give us that challenge of, I don't think you're considering it well enough, and this is how you can do it. So it's a great point, well made early. Thank you.
Thank you for thank you for your response. I've got 3 close adult family members with severe mental illness, so I know a lot of studies have been done on this, and it's quite clear that your life expectancy is decreased if you have a severe mental illness. So I think you can be confident that I will be raising it and challenging it, and where appropriate, of course, because it is something that is of close to heart. Thank you.
Wonderful, thanks for that, Amran. Nicola.
Hi, I wanted to make a comment regarding more on the cancer side. And so, we're increasing our ability to screen, diagnose, and treat a lot of cancers. But I wonder whether the recovery and rehabilitation that is offered at the moment for adults particularly doesn't fit in with the healthy life expectancy. So the services that were available in order to help them recover and then to live well, to get back to work, to live a life that they would like to live when they've been quite debilitated from cancer treatment. I think that is an area that definitely needs some looking. And yes, there's elements of prehab and there are, like things like that can be looked at, but certainly recovery to a lifestyle, like you say, that they would like to lead, that they would like to be able to garden or do whatever they would like to do. But
thanks, Nicola, and I'm busy writing your name down here. I just want to make sure that it's not only me who's answering all the questions, but I've just got an observation before I maybe see if either Tom or Rebecca or Matt or Rob or Ange want to come in on that. Matt and I connected in with a lady called Louise Merriman last week, who's kind of a GP cancer lead within the Derbyshire system. And what Louise was making really similar points to what you're just making there, Nicola. So definitely, I don't want to go too techie here, but there are 3 forms of prevention. There's primary, secondary and tertiary prevention and tertiary treatment. And I think what you're talking about there is tertiary treatment. And I now feel the need to quickly explain the difference. Primary means you stop someone getting the disease in the first place. Secondary means you identify early with the hope of curing or at least really slowing down, and screening is an absolute ideal example of secondary prevention. And then tertiary is you maximise the treatment opportunities, and you make sure that you've got the most evidence-based treatment, and you give exactly what you're talking about there, Nicola, the person in recovery ample opportunity to address. And it takes back to Amran's point, the mental impact of going through treatment as well as the physical impact on the body. So so what we need is people who've got this passion like you have, because we are a few people leading it, but we are not the system. So what we're really wanting to get out of these calls here is who are the correct people to connect in with, who can do this check and challenge and robust holding to account of the system, not of me, but of the system on. We know what makes people ill. We know what works best. How do we make sure that we are getting that to the people who most need the help? And the manner in which we're delivering it, there's a point that's being made in the chat which is very much around health literacy, so that we are making the information available to people and access available to people in a way in which they want to, in which they can then engage. And people such as yourself, Nicola, I can see you've got a real passion in it, are going to be absolutely fundamental. And what we're struggling with is, we're such a massive system, is making sure we're connecting in with the right people. So I've jotted your name down, and I might just be in touch with you later if that's okay.
Yeah, that's totally fine.
Tom, Matt, Rebecca, anyone else want to kind of add to anything I've just said there?
Yeah, I just wanted to sort of bring in, we talked about causes of the causes, and very often we intervene with cancer when people have got a cancer. So part of this key area of focus and this ambitious way of working is actually we look at what are the causes of the causes. So be no surprise, living in a poorer area, poorer air quality, having a poor diet. So part of this focus is that primary prevention. I just sort of wanted to bring that in because, and this links to Jocelyn's question in the chat. We are doing work around working with the groups of people that don't show up, that show up late, and really that's, this is incredibly difficult. This is we've learned a lot through working with COVID, with vaccination. You've got lots and lots of different communities in Derby and Derbyshire, and we've got communities we've missed, and we all as a system need to get better at working with some of those communities and really understanding the lives those people live. So I know in Derby City they've done a lot of work on that, and we're doing more in Derbyshire. So that's going to be, as you said, pick up Jocelyn's question, his cancer question. This is key. It's who aren't we seeing at our services? So and why not? And what can we do to help people get into those services?
Thank you, Tom. Right, so Gillian, and we'll come over to you next. We just want to go to Mark first and just see if there's any questions from the chat.
Yeah, there are 3 questions in the chat. It's quite busy. First of all, Tom, Jocelyn's question, do you feel that your answer covered hers, or do I need to just read that out again for everybody?
Yeah, just if you could read out, because I actually can't access the chat for some reason.
Okay, no problem. So Jocelyn Street has asked, what is the ICS doing to encourage people to make use of the preventative help that is available, and how is it communicating with those who are not engaged with the health service to make use of these?
Tom, could we might want to do a bit of a double act on this, because there's something that and I think we've got Laura on the call as well. I think I spotted Laura's name pop up on the chat earlier. So a really fundamental point around engaging with our communities who are not currently accessing the services that the evidence would suggest they would benefit from is around health literacy. And what we know is that within Derby and Derbyshire, our levels of health literacy, so within Derby City, levels of health literacy are at about 50%. So again, trying to explain that simply, what that means is that 50%, the manner in which organisations within Derbyshire, and I include, NHS, local authorities, some voluntary and community sector, but in general, the language that we use is not in a manner that 50% of the population can easily understand and act on in terms of improving their health, because we lapse into lingo that means something to us and doesn't mean something to the general population. So health literacy is really important, and we did some work. I'm going to give the example of diabetes education. So everyone who is newly diagnosed type 2 diabetic is entitled to access diabetes education programs, which are there to enable them to either reverse their diabetes or to prevent them going on to become insulin dependent. And we know that at the time we did this audit, 25% of people took advantage of the education offer, and 75% of people didn't. So 75% of people who were newly diagnosed diabetic didn't take up this offer of an educational program which would have given them the information that they could have acted upon in order to improve their outcome from diabetes. So what we did was engage with those 75% of people to go, what is it that we're doing wrong, and why didn't, what was it as to why you didn't feel you wanted to come along to those diabetes education sessions? And rooted in it, we found that people from more deprived areas were less likely to want to take up the offer, or were less likely to stay with the whole programme. So they might have turned up once and then they wouldn't come again. And rooted in it was, when we spoke to those people, were issues of health literacy of, I didn't really understand what the term meant. When people started talking about carbohydrates, I didn't understand what that meant. I felt out of my depth with the language, or the leaflets that were provided didn't mean anything to me. And actually that service has now looked to very, very much tailor the resources that they use, and even the way in which they contact people, to ensure that we use a language that is familiar to the very people who we need to engage with and who we need to make sure our services are accessible to. There's a lot more information coming through around health literacy, and Laura, I know you're on the call. If there's anything you want to say, please just pop your hand up. But a lot of the work we need to do with communities is around how is it that we describe our services, or where we publicise our services, that means that that if we do it in a different way, you are more likely to want to engage and more likely to be able to benefit from those services, or to be able to take actions yourself because you understand the messages so that you can act on them. Because not all of this is about someone accessing a service. A lot of it is about simply giving people key messages which inspire them to want to improve their own health themselves, because a lot of it is within our own grasp to do something about.
That's wonderful. Thank you, Jane. Mark, did you say you had 2 more questions?
Yeah, we have 3 more now. So first of all, Sharon Mellors has a nice quick one. Could you confirm that NHS health checks are offered at all GP surgeries in Derbyshire?
Tom, is that one you can answer for us, Tom and Rob?
Yes, it's through a contract through Public Health. So we offer NHS health checks to everyone aged between 14 and 74 without a long-term health condition. And we're also developing a community offer, so having health and wellbeing coaches supporting that process. So yeah, that's a national programme.
Sorry, can I just add in for Derby City, there's a handful of practices that have opted out of the NHS health check contract, but we have Live Well delivering community health checks, so anyone who is eligible is able to access a health check through Live Well if their GP surgery doesn't deliver it.
Thank you. Can I just ask Mark just one more question from the chat, then we'll go back to hands up.
Absolutely. So Sally Morton has asked, will there be work done on how the NHS and other statutory services help to improve the health and increase life expectancy of people with a learning disability?
Thanks very much, Sally. So I think Matt's dropped something to the chat there. So Matt, do you want to come in and answer that question for us?
Yeah, absolutely. So similar, as I've just popped in the chat, but you might not have seen that just yet. It was just to flag that, much in the same way as Jay mentioned about the mental health group in society and other groups in society, if there are groups that are identified as underrepresented in services in terms of people not accessing services to the level you'd expect to see, then that's definitely an area that should trigger action to engage with those communities to consider how can we be more accessible as a system or as that particular service, and that would definitely be the case with learning disability groups alongside others wherever they are identified. Hopefully that answers your question, Sally, but happy to take further on that.
Thank you, Ma. Okay, we're going to go back to hands up. So I'll have Gillian and then Anne. I have got you logged down after Gillian, okay?
Hi, thank you. Hi, Jane. Just for those on the call, my name's Jill Linford. I'm a Quality and Business Performance Manager in DCHS. One of the teams that I work with is our diabetic specialist nurses. So I was just answering your question, Jane, about known gaps. So one of the things that I'm aware of that we went through a gap analysis last year with ICB colleagues. So I just wanted to check that you were aware of that, and it was started by a lady called Louise Clark and picked up by Sam Hardy-Ainger, who I'm hoping that you might be familiar with that already, but if not, there were identified gaps across the diabetes pathway that were picked up last year. I won't go through it, the detail of it on the call, but I could take it offline. But I just wanted to put a pin in that for you, Jane, in answer to your question about known gaps about diabetes specialist nursing and across North and South.
That's really helpful, Jill. Can we pick that up separately?
Yeah,
that's
absolutely.
brilliant.
I mean,
We
there's
want
quite a lot of
to,
detail to it. I wouldn't want to.
Yeah, no, that's great, and kind of a plea out on the gaps. That is really what we're looking for, and you know, an approach that's a term someone told me many years ago, which I live by, is work smarter, not harder. We absolutely do not want to be reinventing any work that people have already done. So please do
There's a big bit of
let
work
us know.
that we did across the system. So
that's brilliant, Jill.
I'm hoping
thanks.
that you're familiar with those two people, Louise Clark and Sam Hardy-Ainger. Are you?
Thanks, Jill. If we can pick it up separately, Jill, that'd be brilliant. Thank you.
Yeah,
that's wonderful. Thank you, Gillian. Okay, we'll come to Anne and then Tracy. Anne.
Yes. I'm sorry, I've missed a couple of things. One was, I was wondering why the cutoff for health checks is 74. It strikes me that with the way aging is going at the moment, you might pick up a lot more from people perhaps extending it to 80 or even 85. It would be, I think, a help and a reassurance for a lot of older people if it was possible to have a health check. There's one thing that I can't help feel that I would like to press, and I'm not sure whether it's quite the right place to be doing it, but I think we really ought to make a great deal more use of our voluntary bodies, because obviously to keep people in good mental health, they require things to be doing. And one of the ladies on one of the previous meetings I've been to was saying that nearly all her volunteers are over retirement age. And it strikes me that you have an enormous pool of people of all sorts, with all sorts of backgrounds, that I feel we could use if we can manage to get in touch with some of them. Unfortunately, during the last 2 or 3 years, there have been so many cuts in funding that I know one or two very good voluntary bodies, in fact, have completely faded because they've been without help. So it might be something that JUDC might have to consider, giving small assistance, financial assistance to some voluntary bodies to get them going again. For instance, I don't know whether they're still going. I hope they are. But my husband attended a prostate cancer group in Cairo direction, who was absolutely marvelous. They had about 50 to 100 people every month there, and my husband found it extremely helpful. It certainly improved his mental feelings about his prostate. And I think if we could tackle some of these things and bring them in underneath our sort of
And I'm just going to bring in Jane at this point, okay? Because we've got two questions, one about the NHS aim limits and then one about the VCSE. So if we just hand it over to Jane just to look at those questions.
Hi, Anne. Yeah, thanks very much. Just on your first point, I'm just going to bring you raised a point around NHS health checks and increasing the age. I'm just going to bring Tom in because I know we had that question on our previous session.
Yeah, thanks for that. I think the simple answer is I don't know the evidence behind why the cutoff is at 74. At the last meeting, I suggested that it might just be a cutoff where people generally then get regular checks through their GP because they're likely at that point to have got a long-term health condition like high blood pressure. I say that's just my guess, but we are going to look into why that is, and we'll put that in a frequently asked questions. We'll understand what support there is out there for over 74s, because you're absolutely right. People are living, well, for some people, they're living longer, healthier lives. So do they need those regular health checks? Thank you.
And I'm just wondering, I can see there's some more hands up. I'm not sure whether you want to do questions in the chat, Beth, or hands up.
If we come back to Tracy and then we'll go over to Mark in the chat room.
Hello.
Hi, Tracy.
Hi. Yeah, hi everyone. John O'Brien here. I want to just mention that our work with hearing impaired people, I think fits hand in glove with a lot of this stuff. I know predominantly, not exclusively, but predominantly it's with age, the issues that we're talking about is to do with age-related illness. And we are here to provide accessibility for people with hearing impairment into any services required. And through that, we provide the hearing impairment service throughout the county on behalf of DCC and what was the Clinical Commissioning Group. And we have a considerable amount of free equipment, personal listeners, all manner of things to help people hear better. Now, if they are trying, attending meetings and so on and so forth, it can be very difficult for them to actually understand and take on board what's being said to them. So the equipment that we provide is a lifesaver. Actually, it's fabulous stuff. We also our outreach workers work at all markets, outdoor markets throughout the county, from Swadlincote to Eckington, Clown and Long Eaton across to Buxton, Ashbourne, and right up it over the to the border. So if there is any leaflet or pamphlet or anything else that you have, if you'd like to let us have that, we can actually feed it straight in at the pointed end, direct into the people that may well need it, in an environment that really is very accessible indeed. Another thing that I would just like to point out briefly, during medication, particularly for cancer, it can seriously affect hearing of people. Hearing can deteriorate incredibly. And again, we're here for that. If we can help anyone with equipment, this is free of charge equipment, and it really is life-changing for them. It increases their quality of life. And then last but not least, end-of-life care. The last sense to go at end of life is hearing. People hear to the absolute end. And so what I have a real thing about is making sure that people can hear right until the end. And again, we have these fabulous personal listeners which enable that. And we do know that it makes things so much easier for family because the people respond to the voice. So that's just a brief sort of what we would like to do to help you with this.
John, that's do you know, that's a face from the past, John. You probably don't remember me, but I remember you
I
from
remember
my
you
days in
very
Amber
clearly,
Valley.
Jane.
Yeah, it's lovely to see you again, John. John, would you mind putting your contact details into the chat so that we can pick up with you afterwards? Because that's an incredibly generous offer and one that will be really valuable to us. So if you wouldn't mind just popping contact details, if you don't mind, that would be brilliant. Nice to see you.
Yes, of course. And you, Jane.
Wonderful.
Thank you.
Here we go over to Mark in the chats.
Okay, we have a question from Amy Baraniak. She said, it's great to see a focus on engaging communities with these priorities to extend prevention strategies beyond healthcare. There used to be a role for health trainers, which were people recruited from communities to work with people within their community on health behaviour change based on priorities. I know we have the services based within public health, but given the focus you've outlined, re-engaging communities, are there any ideas or plans on how to equip communities with capability and opportunity to engage in effective health behaviour change? And is this something that's still part of service design and planning?
Thanks, brilliant question, Amy, and I'm definitely feeling old now because I remember health trainers of long ago. What I'm going to do is ask if Ange, Rob and Tom want to come in to kind of give a bit of an up-to-date picture on what's happening locally within Derby City and Derbyshire. So if I can hand over to Ange, Rob or Tom.
Do you want me to
Brilliant,
try and
thanks,
start to pick that up, Jane? Hi, Amy. Long time no see. So I can just about remember health trainers as well. So within the city, and this kind of goes a little bit towards answering Anne's second point, I think, as well. A lot of our work from a service perspective in our service design is to not just support the individuals that may access the service, but to support those communities where in which people are or are not accessing the service. And a huge part of that is to try and recruit people from within those communities to act as advocates, ambassadors, peer supporters, or anybody who can spread the message, whether it's about the service or whether it's just about how to access something or how they can access things that can support them to make lifestyle change or behaviour change. Then we will offer training to individuals and to organisations to help enable that. Now, we're always on the lookout for opportunities from other organisations to enable us to do that better. So whether it's taking advantage of the kind offers that have been given to enable us to be able to train people in the right way. I think what we need to do and what is being done is engaging better with the voluntary sector to enable us to identify people and also to identify different cohorts or different groups of individuals and different groups of populations that we can't get to. And that all kind of wraps around to try and support as many people as possible, to try and get to as many people as possible. It's quite difficult to kind of design that, but I think we're trying to learn from communities to enable us to be able to design that as best we possibly can. And I guess finally, one of the key points for us in the city is that we are only able to work with a very small group of people from a population perspective. So the best way for us to be able to increase that is to engage with as many volunteers as we possibly can. So for example, all of our walks now across the city, so there are around 12 health walks across the city, they're all volunteer led. We've trained those volunteers not just in walk leading, but actually around behaviour change. So a little bit around that as well, so they can have different types of conversations with people. And that's something we just like to grow and grow and grow. And we don't have to be the holders of all of that. We can just enable people to be able to do that and kind of almost create as many on the ground, live well advocates as possible. Does that go towards answering a little bit?
Yeah, thanks, Rob. That's it sounds really, really good. Thank you.
Mark, I think we've just got one question left in the chat box.
We do indeed. It's from
Yeah.
Robin Evans. Some of our chronic respiratory disease patients with low income struggle to prioritise heating and feeding a family and paying for prescriptions such as inhalers each month. Can there be a review of how to better support these patients, improve treatment compliance?
Brilliant point. Yes, the simple answer to that is yes. Poverty sits behind so many, I've heard some really dreadful stories in recent months around the impact of cost of living crisis on people being able to access treatment options. And it's something that, everyone working with me feels really passionately about. Robin, if you're the right person to kind of connect in with to try and get data, what we want to do is not act on anecdote, act on data. Then that would be fantastic. Yes, it's in the country we're living in. It would be very, very wrong for us to be supportive of a system that means through poverty someone is not able to access their treatment. That's absolutely what the NHS was not set up to do. So yeah, I'd want to be able to connect in with you about that, Robin. Beth, I know we're really pushing up against time, but I don't feel like we've adequately answered the question around the use of volunteers that Anne made and Nick picked back up on. I kind of committed that we would do that. So we are really aware that the voluntary sector and volunteers have a massive part to play in this agenda, because we want to really push, as Tom, Ange and Rob have said, that primary prevention, that's stopping people getting unwell in the first place. And we are really, really keen that we make sure that we engage properly with the voluntary sector around it. And actually, playing to the very first point that Amran made, volunteering in of itself is good for your mental health. So the evidence indicates that not only is it great to benefit from voluntary sector services, it is really good for your mental health and for overcoming issues of social isolation to become a volunteer yourself. So that is something that we really need to ensure that we build up, because Anne makes a very good point that if you look at the average age of volunteers, they are older people, and trying to work out what it is we can do to engage with younger people to become volunteers is something that we're really keen to do. Anybody got any? We do not have all the answers. I'm coming on this call telling you we don't have all the answers, so we really need people's help to help us work this through.
No, thanks for that, Jane. I'm a bit conscious of the time, so I want to thank everybody for coming and just let you explain what the next stages would be. So this is the last of these sessions that we're doing, and what we're going to do is take all of the questions, responses, comments, and compile it all and put it on that engagement a platform that I spoke about. And we will resend you the link out. This video will also go on there, and there'll also be an opportunity to continue asking those questions, continue doing those comments as well. So please feel free to do that. On that engagement platform, we'll also let you know what the next steps are as well, and how you can carry on being informed. Obviously, Jane's will reach out with the people that she's mentioned going forward. But yeah, just please carry on continuing with that discussion and the development of this area. So I'd like to thank everybody for coming, for Jane for the presentation, and all the colleagues on the call as well. And thank you everyone for attending. I wish you a good day.